Okay, everyone, welcome. Thank you for coming. I understand that if you're currently, in school, this is right at the end of the semester. So I appreciate you being here. And if you're not, thank you for being here. Also, it's a beautiful day outside. So today is the last talk in our clinical series. And today we have Katie Smithwick with us. Um, Katie is a clinical pharmacy specialist in psychiatry at VCU Health. She graduated from the VCU School of Pharmacy in 2011 and completed PGY1 pharmacy practice and PGY2 psychiatric pharmacy residencies at VCU Health. She is a board certified psychiatric pharmacist and a board certified psychotherapy specialist. I am incredibly excited for this one. I know I've said this each time, but this series I think has just brought even more information than series one. So, Katie has said that if you have questions, you can interrupt, and I will be monitoring the chat as well. So I'm going to turn it over and let's get going.
Awesome. Thank you so much. I'm excited to be here. I feel like interdisciplinary work is like my favorite part of my job. So it's always fun to speak to people of a different discipline. So I'm excited. I have a lot of slides and a lot of material I'm going to try to get through. So I think you all will also get a copy of the slides as well. So there may be some things that I kind of rush through, or I'll let you know, like this will refer back to this later. And there are also hidden slides in the presentation too. So when you look at them later, there'll be even more information to kind of digest. But yeah, feel free to interrupt me if you have questions. I'll try to breathe to give you a chance to do that. And then of course, we'll try to have a couple minutes at the end for questions too. So the focus today is mostly going to be on majority antipsychotic medications, and then really focusing mostly on treatment of schizophrenia and bipolar disorder. So, of course, my keyboard's not working. All right. So some objectives, we're going to talk about kind of management of antipsychotic and mood stabilizing medications. We'll touch on guideline recommendations for both schizophrenia and bipolar disorder. We're going to go through a little bit about medication selection, dosing, monitoring, and adverse effects of these medications. And then we'll talk about kind of treatment planning from the pharmacy perspective for these things. So kind of starting at the beginning, thinking about how really focusing on antipsychotic medications and how they work. This chart is kind of breaking down. We really think about antipsychotics kind of in two general classes right now, the first generation antipsychotics and then second generation antipsychotics. So for first generation agents, these are also sometimes called typical antipsychotics or conventional or classical antipsychotic medications. These are really our old drugs that at this point we try to minimize use of, but they're definitely there for treatment experienced patients or patients who don't respond to our newer medications. So these are things like haloperidol, fluphenazine, chlorpromazine. So primarily first generation antipsychotics are really working based on dopamine receptor blockade. That's going to give us our most therapeutic effects and adverse effects in theory. And then they also affect some other medications as well. Just checking the chat here. Gotcha. So they also affect some other receptors as well. We kind of consider these like off-target effects of the medication. So thinking about histamine, which really tracks closely with sedation, muscarinic receptors, which basically affinity there tracks with anticholinergic side effects that we'll talk about. And then alpha adrenergic is really affecting, for these medications, we're mostly talking about cardiovascular effects and things like orthostatic hypotension or low blood pressure that can experience with these medications. So for first generation antipsychotics, we kind of divide them out also into low potency or high potency. And this really relates to how much affinity there is at the dopamine receptor specifically, and then also how much of these off-target effects happen. So then kind of in our second umbrella is second generation antipsychotics. As we're getting more and more medications in this class, this is kind of being further divided as well. So in most textbooks and pharmacy references, these are still all considered second generation agents. So for the majority of these, again, we have dopamine antagonism going on in the mechanism of action, but also there are serotonin effects that make them a little bit different. The second generations kind of have varying amounts of effects on those off-target receptors. And then for our kind of newest agents, we can kind of think of these a little bit differently just because their mechanism is a bit different. So the receptor activity, they're partial agonists or antagonists, and this is referring to aripiprazole, brexpiprazole, and cariprazine specifically. So some references, some people are starting to call these third generation antipsychotics, but generally they're still under the umbrella of second generation for now, until classifications are kind of updated. So going back to that kind of low, mid, and high potency for first generation antipsychotics, again, kind of I think the ones that you'll probably have heard of more often, haloperidol or maybe fluphenazine, are really high potency agents. So what this really means is strong dopamine antagonism. So that means in terms of side effects, our extrapyramidal symptoms are the ones that we're concerned most about. So these are our movement disorders, things like akathisia, tardive dyskinesia, dystonic reactions, things like that. So then our other off-target effects, here you can see the low potency agents like chlorpromazine, thioridazine. They're going to have much more in terms of those anticholinergic, sedative, and orthostatic hypotension type side of effects, versus the high potency. Mostly it's going to be, our concern is EPS and less so on those other side effects. So this is not to say that they can't happen in an individual person, but this is kind of how the populations typically respond, or what kind of side effects are typical to see with these based on the receptor affinities. So here's a good example of a slide. I'm not going to read to you dosing or anything like that. That's super boring. I'll try to nerd out on the more interesting things. But here, as a reference for you, just the different first generation agents, a little bit on equivalent dosing and usual dosing. And then there's notations here. Some of these agents are available as short-acting injectable formulations, which might be used for acute agitation in the inpatient setting. We also have long-acting injectable formulations that are kind of more for chronic disease management for these medications in terms of a transition. And then interestingly, one of these is also available as an inhalation powder for acute agitation. So since we first kind of mentioned long-acting injectable antipsychotics, we're going to get more into detail with this, talking about the second generation agents, but just to point out, we have at this point a lot of these options. So from our first generations, haloperidol and fluphenazine both have LAI formulations. These are generally dosed for haloperidol monthly, for fluphenazine every 2 to 3 weeks, and kind of compare that to our newer second generation agents where we have a lot more, and it seems like growing every day. We're getting new versions of LAIs for these newer medications. The frequencies on these is really all over the board too, going from 2 weeks to out to 6 months. So it's getting impressive in terms of the amount of different options that we have for transitioning patients to longer versions of those medications. So this is great from a chronic disease perspective. I could definitely drone on about how it's pros and cons from the acute care perspective. And we can talk more about that if anybody has questions, but it's amazing and nice to see that we have so many different new formulations for patients. I think overall, we do think about LAIs as, while the side effects are similar to the oral medications, overall they tend to be a little bit less comparatively when you just think about less peaks of medication. Basically, you're having kind of just slow, consistent absorption of the medication, which can make the tolerability a little bit better. So that's nice. Obviously, there's a lot of argument that adherence to LAIs, the reason that we use these medications is in patients who don't adhere to their medications. But the counterpoint to that is the patient still has to come to that appointment, have transportation to get there, have the interest in doing that, to follow up, to come to the office to get the medication. So there's still adherence issues sometimes with long-acting injectables as well. So something to consider there. It doesn't fix all the problems necessarily. And as we come out with more and more new formulations, I think you have to think about kind of costs and access for patients as well. So these can be incredibly expensive medications. So insurance status becomes really important in kind of selecting these and figuring out, are they even realistically an option for patients? Some of them have patient assistance programs and kind of ways around that. But that's something to kind of consider. And we think about whether, when we're kind of determining, does the patient need an option that includes an LAI? And will they be able to actually access that in terms of their care, their transportation, and cost? Okay, so here again, we have a very long chart with lots of information. So this one is focusing on transitioning over to second generation antipsychotics and thinking about specifically FDA indications for these medications. So we traditionally kind of think of these as schizophrenia treatments. So you'll see in the first column, all of them have an indication for schizophrenia. The exception with clozapine just being that that one's only technically indicated for treatment-resistant patients, so patients who have failed at least 2 other antipsychotic medications first. We said, and we're going to talk about bipolar management a little bit in the second half of the discussion. Most of these agents similarly are indicated in acute mania treatment and then in mixed episodes as well. And then after that point, it's kind of spotty on these other indications. So some of the drug companies, some of the medications have been studied for kind of very particular patient populations. Interestingly, schizoaffective disorder is one of those. I think in some situations we kind of consider this and what medication we would select for a patient when we really think about their diagnosis, and in some ways that we don't. So I think that's something to point out here. Like I would definitely not argue that haloperidone is the only effective antipsychotic for schizoaffective disorder. That doesn't make sense. I think that's really more just a drug company thing, trying to get a new indication for a medication that no other drug has. Contrast that with the effect of clozapine that's been seen for patients who have chronic suicidality in patients with schizophrenia or schizoaffective disorder. None of our other medications have kind of shown to be effective for that particular indication. So I'd kind of put my stock into that if that was a particular indication that we were seeking for that patient. Kind of similarly with bipolar depression is another area where I do think about indications. And most of that is because some of the agents have more negative evidence, meaning that the studies did not demonstrate that they were effective medications in particularly bipolar disorder, bipolar depression episodes specifically. So aripiprazole is kind of a good example of that. And then on the flip side, only some of these agents have been more particularly studied in bipolar depression. So that means that the guidelines then kind of lean more on those medications for selecting in that particular mood episode. Agitation and dementia is kind of another interesting indication. This is pretty new and I would say kind of controversial. So all of these antipsychotic medications have a black box warning, kind of our highest level of warning for a medication for increased risk of mortality in patients who have dementia and are being treated for dementia-related psychosis. So that applies to all of these medications. They've been shown to increase risk of cardiovascular effects like stroke, and also things like aspiration pneumonia, which we think might be related back to those extrapyramidal symptoms that we were talking about. So people can develop dysphagia, they can aspirate, develop pneumonia, and then unfortunately pass away because of that. So interestingly, in the last couple of years, brexpiprazole, their drug company representative, went for this indication in agitation and dementia. So even though it still carries that black box warning for increased mortality in this patient population, the FDA still also granted it an indication for that. So kind of an interesting controversy in antipsychotic use right now.
Katie, you do have a question in the chat.
Okay.
Do you want me to read it or what's easiest for you?
I got
Okay,
it.
cool.
Thank you. So for injectables, do patients typically have to come into an office to receive them? Or are they available for patients to have at home? So the intention for LAI antipsychotics is really that these be administered in an office. The reason for that is really mostly not really, well, some of them are more complicated to administer, requiring like certain types of mixing and shaking and giving in a certain amount of time. So it can get kind of complicated. But aside from that, it's really important. Again, one of the whole concepts of using an LAI is adherence to medications. So having that in-office administration checks that box because we know the patient came in and got that injection for this month or whatever the frequency is for the injection, versus we know that they didn't come in and get that. So that's kind of an important element to it in terms of taking out that question of whether the patient's on the medication or not, which is one of the big advantages of the LAIs. So really the emphasis is in-office administration. I will say there are some insurance related issues with that though. Sometimes these medications are only covered under pharmacy benefit for patients and their insurance, which means that they can only get them from a pharmacy, which oftentimes means they're picking them up from a retail pharmacy and then they're expected to take them to a clinic for administration. So you can imagine what can happen in between the patient picking up that medication. And we have definitely had people have family members or tell us that they've given themselves their LAIs. But we really do try to discourage that practice overall because of just tracking purposes. Thanks for the question.
I have a follow-up if you don't mind.
Please. Yeah.
Wondering, like, and maybe you don't know the answer to this, but how often is there, I understand the reasoning behind that, but I'm thinking about people who have co-occurring like diagnoses, like who already take injectables like insulin,
Mhm.
or, someone who has shown for, years and years that they can do that independently. Um,
Sure.
like
It's
how,
not really a question of can they do it, I guess. It's
or,
really more of, again, a strategy to try to ensure that we know whether or not they're actually on the medication is kind of one of the advantages.
or okay.
So
I,
I haven't seen in practice anybody recommend it to be done that way. But I get your point that like it's not, it's possible that a patient could in theory do, give
sure.
this injection to themselves and have experience doing that. But
Because I'm just thinking about, and sorry, I know we're getting, I don't want to
you're
like
good.
topic, but I'm just thinking about, like least restrictive, and like autonomy of the patient. And like, I think about my own family member who like this has been brought up to her in the past. And I think part of the whole barrier is like having to come to a place and get it done. Like if she could just do it herself, like she does with every other thing she's done since she was a child,
Mhm.
like it wouldn't be a big deal. Um, so
Sure.
yeah, I'm just throwing that out there because I think
Yeah,
it's an interesting thing to think about. And
yeah.
it's
I
complex.
get what, yeah, no, I think I totally get what you're saying. I can see where that would be a more, patient-friendly way to kind of address the treatment. But then I guess maybe the question would come up, do they quote unquote need to be on an LAI medication? Is this a person who takes medication, by mouth reasonably? And maybe that's a better option for them anyway.
Right.
Um, I guess it's who knows what'll happen in the future with this, but it's not something that I've seen. And I think it's just that question of like, what is the role of the LAI medication? Why are we using it?
Yeah, I
Um,
think.
yeah, of course. Okay, so the next question kind of beat me to my next point here. So aside from the black box warning related to increased mortality in patients with dementia-related psychosis, our other black box warning that we think about with just generally class-wide is related back to suicidality. This is really the black box warning for this is only on those drugs that are being used for major depressive disorder indication, so only in that column. So basically any medication or antipsychotic that's being used in depression management is also going to come with that black box warning that we're familiar with for antidepressant medications. So increased risk of suicidal thoughts. And we really think about this more in our younger patient population. So the data really breaks out to patients who are under the age of 24 in the studies were the ones that were seen to have this effect. So it's not necessarily that suicidality directly has been seen in controlled trials with antipsychotic medications, but it's more of a function of the indication. So it's a little bit backwards, but it kind of goes back to a lot of the side effects that you'll read about with medications. It kind of tracks back to original placebo-controlled studies. They are looking at a population and trying to kind of pin, any side effect that could be associated with that medication or that was seen during the original studies of that medication makes its way into the package insert as a concern. And so it's a more conservative way of kind of conveying information that this association is there. Sometimes these warnings are controversial in the sense that sometimes there's new data that comes out that also like questions these types of warnings and things like that. But the FDA has an incredibly high bar to remove a warning like that from a medication kind of once it's there. So that's definitely an interesting kind of thing to think about as well. So yeah, I would agree. It's more of a correlation due to the diagnosis and it being used in major depressive disorder more so than it is an association with the medications based on the evidence that we have. But I think these are important, like kind of big warnings to know about, because these are the things that patients, obviously, when they get that information on the medication, they're going to read about, and they're going to have those questions, right? Definitely, you're giving me an antidepressant to treat my depression and suicidality, and this paper says that it's going to cause me to have suicidal thoughts. So please explain that to me. You can imagine how that is incredibly confusing for patients and for their caregivers as well. All right. Oops. Okay. So when we think about kind of dosing of medications, I just want to give one example of how there can really be a spectrum of different doses that are being used. I would say doesn't apply to every antipsychotic medication, but some of our medications have, like we said, multiple different indications that they're being used for, multiple different things that they've been studied for. And a lot of times those dose finding studies will end up on kind of leading to different recommendations for what type of dose we should use for those different indications. So I think aripiprazole is a good example. It has, besides bipolar depression, a lot of other indications that it's been shown to be used for. It's gone for, I think, the most indications in the pediatric or child and adolescent population as well. So schizophrenia, bipolar disorder, Tourette's, and then irritability with autism are all kind of FDA indications that go along for that population specifically. So just to kind of give you that picture, the dosing can really vary based on the different diagnosis that you're using it for. Pediatric dosing, of course, tends to be smaller on the lower range. The major depressive disorder dosing for the agents that have been studied for that, it tends to be also on kind of the lower end of the range. So you're typically not reaching the same maximum doses that you would be for schizophrenia or mania management. So just to kind of give you that, that vibe. And, not to say clinically speaking, providers also have their own preferences about how they dose medications. This is really just about kind of package insert dosing recommendations. So from the original studies, how the manufacturer intended it to be used for those different indications. Okay, so here we've got a chart with some of our second generation agents. This is really more just kind of to emphasize, similar with the first generations, talk about our short acting and long acting formulations that are available. And then to look a little bit about usual dosing and frequency of medication. A lot of our antipsychotic medications are once daily medications, so that's an advantage. I would say those that are dosed more often than once daily, we start to think about how easy is this going to be for the person to kind of incorporate this into their life, reliably take it every day, twice a day. That's hard for all humans for sure. So kind of thinking about that. And then a couple of our agents have some kind of unique formulations to kind of consider. Acenapine is one that comes to mind with that, or Saffris. This is not really a new medication anymore. It's definitely been out for more than 10 or 15 years, but it's unique because it doesn't really have a traditional oral formulation. It only has this sublingual tablet, which was really designed to be absorbed under the tongue specifically. It's not supposed to be swallowed. And then a transdermal patch, which is kind of unique. We don't have a lot of patch formulations for antipsychotic medications. So this one kind of stands out in this way just because it has these different formulations, which might be useful in certain patient populations if a patient has difficulty with swallowing, or, say you do have a patient who can't swallow for some other medical reason or something like that. Having the sublingual or transdermal option is really nice. Okay, so this is just the continuation of those prior medication, or the same frequency and dose range for these. The other one that kind of stands out here is ziprasidone, which we'll kind of just flip to this next slide. So kind of thinking about some drug-specific counseling points for some of these medications. Several of them have specific calorie requirements that we have to think about. So thinking about a certain amount of calories that you have to take to basically get full absorption of the medication at that dose. So there's a range. Lorazepam is 350, ziprasidone is 500, lumateperone, which is one of our new medications, is just take with food but doesn't specify a certain amount of calories. Usually these calorie or food restrictions are related back to what's called bioavailability of the drug, basically how much of the drug is absorbed after you take it as a percentage. And oftentimes food can help those drugs with low bioavailability have better absorption. So this is really important because if you don't have the ability to take the calories, then the level of that medication is going to be significantly impacted for these particular examples. So thinking about, again, from kind of like our general perspective, patient has food insecurities or food restrictions for some reason. This might be something we have to think about in terms of like a patient-specific factor that maybe this wouldn't be a good medication for this patient because they don't have good oral intake for some reason. So that may be a factor that we might be selecting against. So acenapine, again, thinking about our sublingual formulation, we don't want to swallow that tablet. So because the absorption is so impacted, it's really designed to be absorbed completely under the tongue. So we have to instruct the patient, and of course, from the inpatient perspective, nursing staff and things like that, that patients are not supposed to eat or drink for 10 minutes after taking that medication to try to minimize potentially swallowing it, essentially. And then the other one on here, paliperidone. So this one's just interesting because it has what's called a ghost tablet. So from a counseling perspective, we like to let the patient know. This basically means that the shell of the tablet can be seen in the stool. And so it doesn't mean that the medication is like passing through and not being absorbed or anything like that. But it's just a commonly known thing for the medication. So to give the patient a heads up, obviously that could be concerning, or if the patient is paranoid or something like that, they might think into that one. So kind of letting patients know ahead of time that that's something that they might experience. So we can give them that good expectations on that. Okay, so getting into side effects a little bit of the medications. And we kind of touched on this with the first generation drugs, but we kind of think about second generation drugs as having kind of more of a variety, I would say, of side effects. So again, this is going to be one of our major factors in terms of selecting between medications. So not only for our treatment naive patients, but also treatment experienced ones, if we know that certain side effects have been problematic for that patient, we can kind of compare these different agents and try to determine what would be the most likely best tolerated medication for that patient in terms of a next trial if they didn't tolerate one for some reason. So the big categories here, thinking about extrapyramidal symptoms. So these are less concerning with second generation antipsychotics, which is good. It's kind of one of the primary reasons why second generation drugs have pretty much replaced our first generation agents. So there's less concern. It doesn't mean no concern about EPS, but less concern about tardive dyskinesia. So whereas with haloperidol, those rates are like 10% potentially for patients who are on haloperidol for long time periods, especially higher doses, might be at risk for developing tardive dyskinesia. This is important because it's potentially irreversible for patients. Even if they stop the medications, that effect might not go away. So one of the big goals of replacing the first generation class is to try to reduce those types of side effects. And so second generations definitely are better tolerated from that perspective, much less risk of tardive dyskinesia. It's variable on the rates that you see, but it's definitely something more in the 1% or less range in terms of risk that you're seeing. The one EPS effect that does come up more with these second generation drugs is what's called akathisia, which is that kind of like internal restlessness feeling like you have to get up and move and work out energy. So some of these agents are more associated with that, kind of especially our newer SGAs, our partial agonist medications like aripiprazole, cariprazine that we mentioned before. Those are the ones that are going to potentially have some more akathisia-like effects. Lorazepam is another one that comes to mind that we've had patients kind of experience that with. So then thinking about our anticholinergic side effects, these are our things like dry mouth, constipation, potentially confusion in older patients. So this is something that we definitely think about as the patient gets older. If they're on multiple medications that have these anticholinergic effects, those can be additive, and that can be problematic. It can lead to delirium, constipation, things like that. So our big offenders here are clozapine and then olanzapine from this list specifically are ones that really stand out. Clozapine is pretty severe, relatively speaking, to the point that it can cause what's called gastrointestinal hypomotility. So slowing of the gut can lead to severe constipation and ileus and kind of more serious complications in some patients. So that's definitely a factor that we think about for those patients, especially when they're on higher doses or again, multiple medications that cause this effect. And then hypotension is really referring mostly to that orthostatic hypotension. So basically when you go from lying to standing, having issues with dizziness or low blood pressure, sometimes increased heart rate as a result of that. And this relates back to the alpha adrenergic receptor effects. So again, clozapine's a bad offender that we think about, iloperidone as well, but quetiapine and risperidone kind of medications otherwise that are thought of as relatively well tolerated can also cause this hypotension effect as well. Okay, so the other big thing that we think about with second generation drugs is metabolic effects. So from an endocrine perspective, prolactin can be affected by antipsychotic medications. This can result in increased prolactin can lead to sexual dysfunction. It can lead to gynecomastia in males. It can also lead to changes in menstruation for females. So kind of some things that we I think don't talk about enough, but need to educate patients more on and be looking out for in terms of that. So this is really more something that we think about with first generation drugs, that like strong dopamine blockade is what's associated with this. But some of our newer agents also cause it. Risperidone is kind of the one that's more classically associated here. So that one sticks out for sure in the second generation class for prolactin dysregulation. Otherwise, when we think about metabolic side effects, we're really talking more about changes in blood sugar, changes in lipids, and weight gain. So this is probably from a class effect, where the first generations, you really say EPS is the big class-wide side effect that we think about. For the second generations, it's really metabolic side effects, weight gain, the development of diabetes, the development of dyslipidemias. So again, it's relative for the different agents. The ones that come to mind in terms of worst offenders are clozapine and olanzapine, and then kind of quetiapine, risperidone being more middle of the road on these types of side effects. And again, some of our newer agents are a little bit better in this way. So aripiprazole, lorazepam, cariprazine, which is not on this chart, and ziprasidone are kind of the ones that have less potential for these metabolic side effects. So this might be a consideration, of course, thinking about other chronic disease that the patient has going on, or might be at risk for based on their family history and things like that. And then this really comes into monitoring for these medications as well. So thinking about how often we need to keep an eye on these different parameters, and also how important it is at baseline to have a measure of this. And again, this is another reason why the follow-up aspect is so important, because we want to track these factors and then be able to intervene if the patient does have significant metabolic side effects, because we know that this is definitely detrimental long-term in terms of cardiovascular risk and just the patient's overall health as well. So this is a big thing. There's definitely been more discussion recently about how do we manage antipsychotic associated weight gain for these patients who have kind of a chronic indication to be on an antipsychotic medication. So injectable medications are definitely a big area that's being looked at right now for this particular indication, but we also have some new medication strategies as well. So one is a combination medication, so olanzapine and samidorphan. Samidorphan is an opioid antagonist, so it's thought to hopefully sort of offset the weight gain that can happen with medications like olanzapine. Right now, it's only co-formulated in this way. And so most of the data really talks about kind of from the perspective of a drug treatment naive patient starting this medication with the goal that it kind of blunts that weight gain effect from ever happening. So it's not as much that we can switch patients and they'll have weight gain or weight loss with this combination medication. So again, still a lot of work that needs to be done. I think probably GLP-1s are more where the bang for the buck is in terms of antipsychotic associated weight gain. One of the downsides to this combination medication, though, because it's an opioid antagonist, patients cannot take it with other opioid medications. So that's something from a counseling perspective and kind of thinking about just safety of the medication and awareness as well. If someone comes in with an injury or something like that and needs an opioid, that's going to be potentially problematic with this medication. Okay, so side effect wise, otherwise kind of think about our cardiovascular side effects besides orthostatic hypotension. QT prolongation is another one that kind of comes to mind. We especially worry about this in patients who have cardiovascular risk factors, or maybe if they've had an MI, they might be already at risk of QT prolongation. Then these medications get added on top of that for some reason. That can be potentially a problem. There are also drug interaction issues to think about other medications that cause QT prolongation. So this is something, again, that we might factor in when thinking about selection of medications. If we know that they've had a prolonged QT or they're on these medications that might put them at risk, it's going to be kind of additional monitoring would be recommended to kind of look out for that. So some of these are really our older medications that are higher risk. Haloperidol, especially when it's given by the IV route, is one of our worst offenders. And then ziprasidone from the second generation class is kind of the one that sticks out there. Okay, so we touched on some of these warnings for second generation antipsychotics. Definitely talked about weight gain, metabolic effects, and how that can increase patient morbidity and mortality. We talked about the black box warning and dementia-related psychosis. We touched on dysphagia and orthostasis. Neuroleptic malignant syndrome is another toxic effect that can happen from antipsychotic medications. You mostly kind of think about it in overdose situations or in situations when patients have been exposed to too many antipsychotic medications. So this is a more serious side effect that can happen rarely from these medications. In pregnancy, most of these medications have been demonstrated to be relatively safe in pregnancy, but there is a potential risk for the newborn that if they've been exposed in utero to antipsychotic medications, especially ones that have a higher risk of EPS, then the newborn can display some signs of EPS or like withdrawal effects essentially after birth. So that's something from a monitoring perspective, especially if we're talking about generally first generation agents would be our higher risk agents there. Some of these warnings are drug specific, so unique to just these medications. So with aripiprazole, there's a warning about compulsive or uncontrolled urges that lead patients to behaviors like gambling, binge eating, shopping, or sex, and experiencing those kind of compulsively. Acenapine, we talked about that sublingual formulation. Interestingly, it has kind of some allergic reactions that have been associated with it. This is kind of unique because you don't really think about too many allergic reactions or anaphylaxis with antipsychotic medications in general. That's a very rare effect to see, but it has been reported more so with acenapine. So that's something to be aware of, and I imagine might be related to the formulation of the medication more than the medication itself. Clozapine is also unique that it has a lot of box warnings. So in addition to the increased mortality in dementia-related psychosis, clozapine has 4 other ones that are just specific to it. So severe neutropenia is the one that we used to have a REMS program that required monitoring for neutropenia. That was actually discontinued a couple of months ago, so kind of in transition out from those additional requirements that were there for dispensing of the medication. But needless to say, that doesn't mean that the warning is not still there. So monitoring is still required for this association with severe neutropenia. Clozapine is also associated with seizures and kind of has a dose-related reaction that can happen with that. So again, thinking about when the level gets too high or in an overdose situation, patients might be at risk for seizures. Orthostasis is an issue with clozapine, but I would say kind of relatively to the max, more so than with other agents. So there is a warning specific to that particular risk. For this reason, adherence with clozapine kind of becomes very important because it's essentially a safety consideration. If a patient were off clozapine for more than 48 hours, they may be at risk for these orthostatic episodes if they were to restart the clozapine at the prior dose. So there's recommendations for increasing the medication over time. So if patients are not able to be adherent to it, that might be a safety concern, just from this perspective specifically. And then myocarditis is another cardiovascular box warning for clozapine that, again, we kind of think about increased monitoring, especially in the beginning time of taking the medication. And then finally, there are some skin reactions that have been associated with antipsychotics. So something called DRESS, which is basically like an allergic type reaction, but it involves skin reactions. And so certain agents like olanzapine and ziprasidone have been associated with that particular effect. So you can see a lot of different types of reactions that have been associated with these medications, but interestingly, some of them are specific to specific agents. So this is the monitoring recommendations for clozapine, and just opening the chat here. So you can see for the first 6 months of treatment of clozapine, weekly blood monitoring is required. Then for the second 6 months, every 2 weeks, and then after that, monthly, essentially ongoing right now. So patients end up basically with lifelong labs at this point if they're on clozapine. There are definitely expert groups looking at changing that, but as of right now, that's how it stands. So you can imagine, again, from that, like access to treatment, transportation, and also patient willingness to do that. Doing something every week is a lot. It's a lot of coordination. Also, the filling of medications is on this schedule as well. So if you're on weekly blood work for the first 6 months, you have to get your prescription filled every week for a weekly supply. So it's just kind of a nightmare from the transitions of care perspective, and just in terms of like patients being able to actually access treatment in that way. Okay, question was, do skin reactions typically take place in a specific place on the body? No, I don't think so. These are oftentimes pretty serious reactions when they happen, and they can be multiple different areas and not necessarily contained to a certain type of area or rash. And of course, that's the most serious concern, which is very rare. That we're back to LAI formulations, looking at the second generation drugs. So again, not going to read to you, but just this is really to demonstrate how many options there are. And it's for different agents as well. Some of the agents have multiple different brand names, different types, different frequencies that are available. The kind of one of the big differences that we think about for LAIs is how do you start the medication? Is there oral overlap required when you give the first injection? Does the patient have to take oral medication for a certain amount of time? Obviously, for certain situations, especially if there's a concern about adherence to oral medication, that may be something that is a deciding factor between the agents. Some of them don't require the oral overlap at all, and then some of them have longer periods, like up to 3 weeks. So that may be a consideration for certain patient situations. The other thing to consider is, if frequency matters for the patient, then is that something we want to like target a certain medication to try to target a medication that we can give less frequently overall. So paliperidone or Invega products are the ones that come to mind for that. It's like Invega Sustenna is a monthly formulation. There's also Invega Trenza, which is every 3 months, and then Invega Half-Yera, which is every 6 months. So if the goal is to try to, like, over the long term, get the patient to a regimen where they have the option of having much less frequent injections, then that may be a target to try an oral trial of paliperidone to transition them to one of these longer acting formulations. My little box here, always use oral medication first. So this, we really emphasize that the best practice for these is a trial of oral medication to try to determine, is the patient going to tolerate the medication? Not just from the sense of like, okay, they have one dose, they might have an allergic reaction or something like that, but really getting up to a good dose to try to assess what these other side effects are going to look like. And then using that as a basis of information to determine what is the long-acting dose going to be for that patient. Sorry. I don't know how I got to the end there. Here we are. So always using oral medication first really helps us not only determine, is this going to be an effective medication for this patient, but also, is this going to be a medication the patient can realistically target or tolerate long term? So keeping in mind that once we give these long-acting formulations, there's no way to take it back. There's no antidote. There's no way to remove it from the body by dialysis or something like that. So it's really important then to understand how the person is going to tolerate this medication at the dose that you're giving them. So we really encourage those oral trials first, and then the LAI being kind of a longer, more chronic medication, more way to transition the patient to longer term treatment after that. All right, so in addition to those on the prior side, there are, again, it seems like every day, more and more new formulations of these medications coming out. So it's not to say that these Hafyera is novel, because obviously every 6 months is a big deal. We don't have any other agents that have a duration that's that long. Otherwise, a lot of these newer formulations are basically kind of like branded generics. It's a new version of the medication, but it's not necessarily different in terms of what we think about, like, oh, this is a new exciting option for patients to try. It's sort of just a new, different version of the same thing. So especially these like Erzofri and Rykendo, this doesn't really offer me a lot of advantages versus Hafyera, where again, you have that advantage of the frequency. Uzedy is one of the new risperidone products. This is nice. We don't have a lot of subcutaneous LAI medications right now. So most of these are intramuscular injections. Some of them, especially for a longer duration, can be a very large volume, and that can mean an uncomfortable experience for the patient when it's administered. So the subcutaneous injections, it tends to be a smaller volume. So in theory, maybe a less painful injection for the patient. So that might be making it a little bit more patient-friendly in a way. So that's nice. Risperidone, as you saw in the prior slide, our version was really Risperdal Consta, which is only every 2 weeks. So that's pretty frequent at this point with, again, these other options. It's not as appealing to have something every 2 weeks versus every month or every 2 months. So it's nice that Uzedy gives us this dosing to be able to dose it a little bit less frequently with every 2-month dosing. Now, with all of these new agents, again, new means expensive to me. So these things are on patent for a long time after they come out, and they cost a lot of money. So insurance companies do not want to pay for them as a result of that. So there's often a lot of times prior authorization processes, peer-to-peers, like a lot of hurdles to jump through from the insurance perspective to get these approved. So that can be troublesome with some of these medications, and sometimes a barrier for patients. Sometimes we can never even get there because of the type of insurance that they have. All right, we mentioned our first generations have an LAI formulation. So haloperidol is monthly. Fluphenazine deck is usually every 2 to 3 weeks. These are a little bit different in their dosing strategy because it's a little bit more straightforward than some of our newer antipsychotic medications. So again, really emphasizing we need to kind of know what's the dose requirement of the patient. Once we know that from an oral perspective, we can convert them then to exactly the same equivalent amount of an LAI formulation. So I appreciate that aspect just from the dosing being a little bit more straightforward of these than with some of the newer drugs. All right, so thinking about kind of our goals of treatment from a pharmacy perspective, and this is really focused more on schizophrenia management. So, of course, we want to always have realistic goals for our target symptoms. We know that patients can have a variety of different types of presentations and also a variety of functioning pre-morbid before their diagnosis. And after diagnosis, they can definitely have a great deal of differences in terms of the symptoms that they demonstrate and kind of what their psychosocial functioning can look like. So we want to make sure we set realistic goals. From the acute kind of perspective, reducing agitation and aggression, kind of normalizing some of those physical symptoms that patients can have. So normalizing their sleep, normalizing their oral intake. We want to try to reduce positive symptoms and reduce negative symptoms wherever possible. I will say most of our medications, antipsychotics, really do a better job at treating positive symptoms than they do at treating negative symptoms. So that's kind of still an area where we need more research and more good options to try to help patients. Of course, we always want to minimize side effects. We want to think about improving adherence. So whether that's through education or non-pharmacologic things we can try to teach the patient, whether that's through trying to use apps or caregivers to help us with things like that, or formulation of medication like with an LAI. Of course, we want to prevent relapses, kind of especially in a disease state where we know that more relapses lead to worsening disease and poorer functioning over time for a lot of patients with schizophrenia. And then kind of think about the patient-specific goals. So depending on where they're at, what their goals are, does that have to do with their job, their life otherwise, relationships, housing, all of those types of things as well. Definitely, I think with schizophrenia, obviously it's an interesting disease state because insight is something that a lot of patients are lacking. So the adherence piece tends to be very difficult. Why would you want someone to take, why would you give me a medication if I don't have an illness? I don't understand why I would take a medication for that. So sometimes kind of thinking about it through the patient's eyes more in terms of, well, what are the goals that you want to meet and how could this medication or this treatment plan kind of help you meet those goals specifically, rather than focusing on just you have a disease and you need to take a treatment. So timeline in terms of kind of using antipsychotic medications, how quickly do they work? Within the first week, we should be seeing some effects. So from the acute perspective, it's not realistic necessarily that we're going to have full change in the patient's symptoms or full resolution of those symptoms. If they are going to fully resolve, it may not be in that kind of acute time period of a hospitalization, but within the first week, we should have less agitation, less aggression, less behavioral disturbances. Again, those physical symptoms should start to show signs that they're getting a little bit better. Hopefully mood will improve within a couple of weeks. And then a little bit longer for positive and negative symptoms. So 6 to 12 weeks is probably a reasonable expectation, but it can take even longer in some patients. And especially if they've been chronically ill or haven't been treated adequately, it may be a little bit slower in terms of the full improvement. I think this is important to keep in mind, again, in terms of like how we try to manage the medications and side effects. With antipsychotics, we really try to use the least amount of medication that we can to meet the patient's treatment goals and to treat their symptoms. So we have to kind of keep this in mind that, acutely, we might be more aggressive with the dosing of the medication. We might be trying to get the patient well more quickly, but is that really a good goal when that may not pharmacologically make a lot of sense when we know that sometimes these symptoms take a lot longer to resolve. So we have to kind of manage our own expectations sometimes from the acute perspective and kind of keep in mind the more aggressive we are with antipsychotics, the more likely we're putting the patient at risk for these side effects. Some of those can be long-term or potentially irreversible if those medication doses aren't reduced. So it's really important to balance those two goals at how quickly we're getting a person better with just the reality of how long it sometimes takes for patients. So duration of treatment wise for antipsychotics, After a first episode, it's recommended that patients be continued on these for at least 18 months after they've had remission of their symptoms. Some of the recommendations are for even longer treatment. And of course, for more chronically ill patients, these are generally indefinite treatments that we would recommend the patient stay on. Again, kind of thinking about that potential for relapse as being very high. So within the first year, up to 30% of patients will relapse. And after a year, on no treatment, up to 60 to 80% of patients will relapse. So really, the American Psychiatric Association recommends this is long-term chronic treatment for these patients. If we know that they have schizophrenia, we know that they're going to need to be on these medications. So it's even more important than to think about from the long-term perspective, how can we reduce the potential for their side effects using the lowest effective dose of the medication. So this is really kind of the opposite of the treatment rationale that happened in the 1950s when we saw a lot more tardive dyskinesia. Back then it was kind of more titrate up until you see those side effects, then you know that they're on enough of the medication. So now we're definitely taking a full 180 from that, and more conservative treatment is probably better to start with anyway while you're assessing the patient. So it's not to say that we won't have patients who will require high doses or will require multiple antipsychotic medications, but that shouldn't be the norm necessarily for the patients overall. Okay. So thinking kind of generally, this can really apply to both schizophrenia and bipolar disorder, but just some of the things I think about from a patient evaluation perspective when I'm thinking about a good medication treatment plan. So, of course, current symptoms and their stressors as well, thinking about how we can address those, usually from a non-pharmacologic perspective or therapy-based interventions. Of course, mental status examination gives us a lot of information on what are the target symptoms for that patient, what are the most distressing symptoms that we need to be focusing on. Definitely thinking about their past history, their past treatment history, and that includes medications for sure. So a lot of the patients that I encounter have been on treatment for a long time. They've tried a lot of different things. So getting to the meat of all of the details of those trials is really important to not reinvent the wheel, and to try to really make a good treatment plan that's thoughtful based on what they've already tried and either had success with or had side effects with or failures with. So we can kind of take that information and make the best plan, use the time wisely, basically. Family history and even family history of response to medications, genetically speaking, can sometimes be helpful information as well. Of course, trauma history we want to take into account also. Other medical conditions, again, kind of thinking about, okay, what are the most likely side effects for this medication? For this patient, what are the things I need to avoid? Kind of focus on from a medical perspective as well. Substance use history, of course, is big in both of these disease states. So high co-occurrence, and kind of thinking about how does that also aspect fit into the treatment plan for the patient? What are the other kind of resources and things that they might need, or other medication treatments that they might need to address substance use? Of course, medical evaluation, basic lab work. So definitely there are, especially when you think about bipolar disorder, medications and other medical situations that can kind of precipitate manic episodes or precipitate depressive episodes. So kind of making sure we're addressing the whole picture and the whole patient as well. Current medications, where we are, do we need to think, is it a situation of where we need to think about dose adjustments or optimization of medications or augmentation of those medications with another thing, versus are we starting from scratch? Of course, drug allergies and again, intolerances, suicide risk for the patient may come into factor, and then barriers to adherence to treatment. So how can we kind of, for this patient, based on what their situation is, how can we address and make a best plan to kind of set them up for success in terms of taking their medications? All right. I think
Katie, you have a
yeah,
note in the chat as well. Okay.
I was just going to read it. Thank you. I've got it up now so I can try to keep it all straight. So I think it's an important point regarding conservative treatment, even in the acute phase, due to the risk of side effects. Do you suggest starting at the same doses as you would outpatient and then using PRNs as an adjunctive option for additional symptom management? So I have to say it depends. I think from a general perspective, we are going to be more aggressive with dosing on an inpatient perspective. A lot of the, like, when you look up in package insert, kind of those dosing recommendations that are there, it's really more triggered to an outpatient titration of medication typically. So I think there's definitely, from an inpatient perspective, we're going to often be a bit more aggressive with that. I think one of my roles in being there kind of in the team is to kind of assess that, look at that. How quickly are we titrating the medication? Are we going up every day? And is that appropriate? And sometimes it depends on by how much are we increasing the dose every day? And is that going to be appropriate and safe? So I do sometimes get in the position of kind of being the person that's kind of holding up the flag, like, hey, wait, we're doing a lot, or this patient is demonstrating side effects at this dose, so they're only going to be at risk for more side effects as we kind of aggressively go up. So should we stop for a couple of days and kind of assess where they're at? We do definitely use PRN sometimes more liberally, again, in the inpatient setting. But I wouldn't necessarily say that we would kind of use that as a strategy. Like, I do think oftentimes there is justification for being more aggressive of the dose titrations in an inpatient perspective. But I think it's just balancing that and kind of monitoring the individual patient, looking for those side effects that we know are most likely going to happen. And then, I mean, overall, I think I want to minimize PRN usage in the sense that it's there as a safety net. It's there to treat acute agitation or kind of acute symptoms that the patient is experiencing. But overall, we don't, if you set up the situation where the patient is going to require a lot of PRNs, we don't really know then what is the scheduled regimen doing and what is this going to mean outpatient when they don't have access to those extra medications anymore. So you kind of have to look at both pieces, I think, in making a good plan. Hopefully that makes sense and answers your question, Stephanie. But I think, it's a balance. Again, inpatient, we're trying to get the patient well as quickly as we can, but also I'm trying to do it in the safest way that we can and in a way that's going to be tolerable for the person after this hospitalization. Definitely the easiest way to get a patient to not be adherent to a medication is to start something that they don't tolerate, be really aggressive with the dosing, cause them bad side effects. Of course, why would they want to continue taking that medication? So that can really be a balance that we're trying to strike when a patient is very sick and kind of needs that more aggressive treatment up front. Okay, so kind of thinking again about how am I choosing a medication treatment for my patient? Kind of focusing here more on schizophrenia. I have another one of these for bipolar disorder. So patient preference, we always want to kind of think about that. What is, again, you need the patient buy-in with all of these interventions. So if the patient's not on board, it's going to be an uphill battle in kind of getting them long-term to stick with this medication. So I believe that we need to try to incorporate the patient preference as much as we can. That can be very difficult when the patient is very psychotic. And sometimes we do have to take more of a paternalistic role in choosing interventions for them. And that's where I'm kind of taking into account, what do I know about the patient and their past trials and what they've tolerated or not, so I can kind of try to make the best plan that I can on that person's behalf if they're not able to communicate those preferences to us, like might be in the case in severe psychosis. So thinking about that for the particular medication, what are the side effects that are most likely to happen, and how do we mitigate those for the patient, or do we not choose that particular treatment because we know that's a concern for the patient? Again, cost and formulation, I think we talked about enough to say these are factors that go into definitely my day-to-day decision making. Again, just thinking about, we want it to be a good plan that's realistic for the patient, that's going to be accessible to them as they go forward in treatment. So kind of a treatment algorithm for schizophrenia. This is just a suggestion. This is not to say that this is what every provider is going to go with, but an example to kind of go off of. So for treatment naive patients, we want to think about what are the better tolerated antipsychotic medications. So some of those might be aripiprazole, risperidone, or ziprasidone potentially. If it's a treatment experienced person, again, we're getting more into what have you tried before and what are our other options? Would they be good options realistically for you to consider based on your side effects? If patients don't respond, then we try to do switches. So we really want to try to emphasize antipsychotic monotherapy and not doing combination antipsychotics if we can avoid it. If they do have multiple failed trials, that comes later in the algorithm, or you might be combining medications. Once patients have had at least 2 failed trials, we should be encouraging clozapine trial at that point. That's a loaded thing, obviously, and a lot of times we reserve it realistically for later in treatment, mostly because of all the logistical issues that go along with clozapine, even though it's our antipsychotic that has pretty much the best efficacy of the bunch. We don't have a lot of comparative information, but the information that we have demonstrates that clozapine is a better, more superior antipsychotic. And then so you see antipsychotic combinations kind of come at the end. Most of that data is really with clozapine combined with other antipsychotic medications, not necessarily the other combos. So the evidence is not super strong for that. But again, in practice, it's something that we do see relatively frequently. And then LAIs can be considered in really most of these different stages. So we don't usually recommend them right off the bat for patients. Really, it's usually after they've kind of demonstrated oftentimes that they are not going to be adherent to the medication, but that's not to say that it couldn't be an option earlier in treatment for patients, again, with that goal of staying on the treatment for a longer period of time. All right, so now we're going to move a little bit into bipolar disorder. Time's running low, so I'm going to have to be a little more brief than I wanted to be, but that's okay. So here in choosing medication treatment, the other thing that kind of comes into mind is those other mood states that the patient might be experiencing. So we really have to say, what are the symptoms that are in front of us right now? What type of mood episode are you experiencing right now? And that's going to drive, are we treating mania? Are we treating depression? Are we treating more of a mixed episode? We have kind of different treatment algorithms for those different situations. And then otherwise, it's all the same things that we talked about before. So all of those patient-specific things kind of go into the mix. There's a little bit more here when we start to talk about mood stabilizing medications in terms of concern for drug interactions, requirements for lab monitoring and things like that. It gets a little bit more intense on that end. So sometimes there's more to consider there when choosing between the different agents. Generally, though, again, we have pretty similar goals of treatment that we're thinking about for this. So we want to eliminate the current mood episode that the patient's in, get them back to euthymia. We want them to have complete symptom remission wherever possible, and we want to try to prevent recurrences of disease. So that's really where the focus is. Mood stabilizing medications are drugs like lithium or valproic acid are kind of going to be our cornerstones for mood stabilizers. And then more and more atypical antipsychotics are again being used in bipolar disorder management as well. So they are, as the years go on, there's more and more antipsychotic use for bipolar disorder patients to the point now where a lot of them have indications even for maintenance, and some of the LAI formulations are now indicated for use in bipolar disorder. So the whole treatment has kind of shifted a bit to more emphasize, I would say, antipsychotics in practice, for good or bad. So our kind of old school mood stabilizing medications still, though, are our backbone of treatment. So lithium and valproic acid kind of being our classic mood stabilizers. I would kind of consider these first line agents. Carbamazepine, oxcarbazepine over on the side here, not as much considered first line. They have some issues and drug interactions, reasons that we don't use them as often in practice. And then lamotrigine, I would think of more from the perspective of bipolar depression management and potentially sort of like maintenance, prevention of mood episodes. That's what its FDA indication is for. So lithium, again, kind of our gold standard. We really think about this for euphoric mania patients, but it also has definitely effects in terms of prevention of mood episodes and then antidepressant effects as well. And this is the second medication we're talking about in this lecture that has some evidence that it decreases suicidality. So only a couple of medications have shown that, lithium and clozapine, in certain patient populations. And for lithium, this is really thinking about in bipolar disorder patients specifically. So dosing of lithium is kind of variable. I won't go into details, but we do think about kind of the age of the patient, their renal function, and then there's a lot of drug interactions with this one. So we have to kind of consider that when we're selecting the medication. You know, are they on interacting medications? Can we dose adjust the lithium safely, or do we need to kind of consider some alternative? We do use therapeutic drug monitoring for lithium. So levels become really important. So then kind of thinking about that, is this the type of patient we're going to be able to get lab work in relatively frequently? Are they going to be willing to do that? This is important for lithium because we have kind of a narrow window that we're looking at for treatment. The numbers that we're looking at are very close together. So the risk for toxicity then is a little bit higher. So a little bit more of a safety concern in terms of the need to monitor levels for this one. And then we have some other lab monitoring that's important. Lithium is considered a teratogen, and then it has some other metabolic effects on electrolytes and kidney function. So some kind of longer term monitoring that needs to take place with it as well. So again, kind of thinking about the drug interactions piece, most of these are blood pressure medications that become super relevant in terms of risk of toxicity. So this is just something we would take into account in the kind of dosing of the medication. I'm going to skip forward a little bit just because we don't have a lot of time left. This is talking about lithium side effects and toxicity. So then contrast that with valproic acid. So this is kind of our first line alternative to lithium. Indication is really for treatment of acute mania, but it has a lot of good evidence as well as a preventative strategy also. So kind of a backbone treatment for long-term management too. Compared to lithium, it might be a better agent for mixed episodes, irritable mania, or patients who have rapid cycling. So sometimes kind of clinically, we might think about the presentation of the mania that the patient's experiencing and choose between lithium or valproic acid as a result of that. Dosing with valproic acid is a little bit more technical. So typically we're looking at weight-based dosing with this one, but it can depend based on the formulation that you choose and the dosing frequency that you want to use in terms of how you're going to start dosing. The dosing a lot of times is more aggressive for acute mania. So again, from that kind of inpatient perspective, we might be starting higher doses compared to a situation where we just need to kind of get them on a maintenance mood stabilizer, or maybe when we're using it in an older adult, we might be more conservative with the dosing titration. We have therapeutic drug monitoring for valproic acid, but it's not as much of a safety thing. The therapeutic index is a little bit wider. So that's good because it means that the risk of toxicity is there, but you have a wider range that you're kind of working with. So it makes it a little bit more friendly in that way. There's a little bit less concern about that in terms of the safety aspects of it. But we can still use a therapeutic drug monitoring to tell us, like, is this person on a good dose? Can we increase the dose? Or if they're having side effects, we can use it as a tool to kind of monitor for that. Again, there are some other lab monitoring and medical things we think about with this. So pregnancy status, liver function, platelets, and there's some drug interactions too that kind of come into mind here. So especially if the person is on lamotrigine, there's a significant interaction that affects the dosing. All right, so skipping a little bit. Lamotrigine is the last one I was just going to touch on, just because I think of the mood stabilizers, these are the ones that kind of come up more often. So again, lamotrigine is really more about maintenance treatment and treatment of bipolar depression. We don't really recommend it for treatment of mania. It takes too long to titrate, and it hasn't really shown to be effective for mania for patients. So it's not really a drug of choice there. This one also, it lends itself to a chronic medication because it takes a long time to titrate up. So the recommendation is to titrate basically every 2 weeks until you get up. So it takes about 6 weeks to get to a therapeutic dose. So that's a downside in terms of the number of steps you have to take. But this is really a safety precaution because lamotrigine has been associated with some serious rashes like Stevens-Johnson syndrome. So it's been shown that basically this slow titration decreases the risk of that happening. So it is an important thing to follow. It just makes it a little bit take longer to get to a good dose. So again, there are some drug interactions to consider here too, especially with our other anti-epileptic medications, and then also some with oral contraceptives that we have to take into account. Lamotrigine doesn't really have levels, so there's not really a good therapeutic range. You can check levels, but they're really used more in seizure disorder management than they are for bipolar disorder specifically. So those numbers don't really tell us a lot in terms of, is this person going to respond at this number? The evidence just really isn't there. So not as much of a tool for this one. All right. So then we kind of touched on the indication slide. Antipsychotics for bipolar disorder. So we have kind of more agents that have been looked at in mania management and a little fewer that have been studied and shown to be effective for bipolar depression. So again, this is kind of something I think about in terms of what's the patient presenting like, what are their symptoms, what is their mood episode, and that might guide our antipsychotic selection a bit because of this evidence that kind of guides the indications for this case. So kind of touching just really briefly on treatment of mania and treatment of depression. So when we think about mania specifically, we always want to think about what are the potential causes? Are there medications or other medical illnesses that we need to address for these patients? If they're on any of those medications, antidepressants is kind of a classic example. If they're on an antidepressant medication, they need to come off of that medication if they're acutely manic. Oftentimes we kind of treat that as a quick taper off the medication because those antidepressants can just prolong and worsen mania. So if they're on a mood stabilizer already, we're going to try to think about, is this a drug where we can check a level? Can we use that to then optimize the dose of the medication? And then what else are they on, or do we need to think about adding additional agents on top of that? These patients do oftentimes end up on combination therapies. Usually that combination, though, means mood stabilizer and antipsychotic medication. It shouldn't necessarily mean multiple antipsychotic medications, again, for the general patient. And then always thinking about the non-pharm stuff. So kind of we need to address sleep for a lot of these patients because that can be a big trigger, but also kind of psychosocially, where can they reduce stress and things like that. Sometimes there can be those certain elements for that patient that can trigger manic episodes. So figuring out what is that patient-specific factor and then kind of tailoring some of the treatment to that as well. So kind of for our treatment algorithm, on the left, we're often going to choose either a mood stabilizer or a second-generation antipsychotic. Or if they're very severely ill, then we might choose to start both, which is a guideline recommended intervention for acute mania specifically. So you have kind of our lithium and valproic acid plus one of the antipsychotics that has been studied. These alternatives, this is really my recommendation, just thinking about side effects wise, we probably are going to avoid olanzapine because of the metabolic effects, and then ziprasidone, more QT prolongation. It's a twice daily medication that's not as patient friendly. So that's why those are listed as alternatives here, not to say that they don't have good evidence in acute mania. All right, so again, we're tapering and discontinuing things that are worsening mania. And we might be thinking about other adjunctive treatments, especially during the acute period too. So if they're having really bad sleep disturbances, do we need to think about a benzodiazepine or a Z drug like a zolpidem, Ambien to treat insomnia? And then if they're very agitated, do we need to think about kind of short-acting antipsychotics for management of agitation just during the inpatient treatment for the patient? In terms of assessing treatment, so if a person's manic despite kind of that initial regimen, then we might need to go back to the drawing board. Have they been adherent to the treatment? What are they taking? What are the doses that they're taking? Can we do that therapeutic drug monitoring and try to kind of optimize things from there? For maintenance treatment, again, this is kind of similar in that patients might be on higher doses of medication during the acute period than they're necessarily going to need for long-term management. So oftentimes after a few months after hospitalization, that should be being reassessed in terms of can doses be reduced? Could they be reduced to one medication if they had to be started on 2 medications to treat that manic episode? And then can we taper and get rid of any of those extra medications that they don't need anymore once their sleep is more regulated and that kind of thing? So bipolar depression, again, very similar in terms of the treatment rationale, except now we're looking for medical conditions or medications that can cause depression, and what are those kind of offending agents that we need to stop. Here, again, if they're on a mood stabilizing medication, we might be thinking about how could we optimize that mood stabilizer, and then how could we think about additional agents that are going to make sense, that have been studied and kind of shown to be effective agents like antipsychotics in bipolar depression specifically. So similar kind of thing, thinking about mood stabilizer or antipsychotic or a combination of the two. And then antidepressants get in the mix here. It's a little bit controversial on antidepressant use in bipolar disorder. There's that concern that antidepressants might increase the risk of mania. They might increase the number of manic episodes that a patient has over a time period if they're on antidepressants long term. So it's something to kind of assess. If the patient's had a history of manic episodes, we're probably not going to choose antidepressants first. But that being said, bipolar depression can be really hard to treat. So sometimes we do end up using antidepressants even though we know about those risks. And this is kind of a summary of that, just saying that kind of the literature agrees that we really shouldn't use them if they've had mania in the past, and especially if they've had mania as a result of taking an antidepressant. That's an easy win, that we probably shouldn't be doing that. So generally, if we're going to give antidepressants, usually we're going to recommend that they be on a mood stabilizer or be on a second generation antipsychotic to kind of lessen that risk for switch to mania. So no monotherapy antidepressants in bipolar disorder. All right, so similarly, thinking about how can we kind of reassess the treatment that we're doing for a patient if it's not working well. Sometimes multiple drug combinations are needed in bipolar depression and also in mania in certain situations. So kind of what are more pharmacologically savvy combinations that we can think about, like things that have different mechanisms of action and then things that can be safely combined. So something like lithium plus lamotrigine or lithium plus quetiapine is one that's guideline recommended. And then if they need a third drug, again, considering maybe an antidepressant, at least for the short term. And usually we would try to not use those medications long term once the depression has resolved. All right, that's all the prepared material. Let me go back to the chat here. And I do want to tell you, once you get these slides, there are also slides after this point. They're focusing mostly on antipsychotic medications, but you'll see that there's a lot more information, so you have that as a reference for you in the future. Okay. Is there a treatment algorithm for every diagnosis? No, I would say unfortunately there isn't really. The guidelines are, there are guidelines for a lot of diagnoses in psychiatry for pharmacologic management, so those can be really helpful. Some of them are outdated or need kind of readdressing, but definitely doesn't cover necessarily every single diagnosis. And of course, you can imagine all the variety of presentations and combinations of diagnoses that patients can experience. So pharmacology in psychiatry becomes more of an art, kind of a gray area. We do have some good evidence, some good guidelines that give us a place to start. But when you honestly read the schizophrenia guidelines, for example, there's not like 1, 2, 3, these are the drugs that APA recommends that we use, because again, lack of comparative evidence. So then we kind of fall back on patient-specific factors when we're selecting the medications. Why is there only one FDA-approved medication for schizoaffective disorder? Is it because of the complexity of the diagnosis or because designated studies for schizoaffective treatment are rare? Interestingly, a lot of the schizophrenia studies that you see, a lot of times they include patients with schizophrenia and with schizoaffective disorder. So the literature a lot of times doesn't differentiate them. So I think that's interesting. I don't want to be a drug company hater, fully, but I am. I'm skeptical of the reason why there's only one medication for schizoaffective disorder, and I think it's because they were trying to do something that no other drug had done and say this medication is the only one with this indication. So I don't really buy into that means that that medication is necessarily better. I think that's a little bit more of a marketing trick, if anything. All right, do patients go through withdrawal when abruptly taken off mood stabilizers? They certainly can. With our mood stabilizers, especially anti-epileptic mood stabilizers, because of that change in physiology, patients in theory could be at risk for seizures if they were abruptly stopped from Depakote or carbamazepine. So we always recommend to taper those medications. And just for psych meds in general, I would say tapering more often than not is recommended, unless there's some kind of like serious medical concern that's going on, that we need to abruptly stop that medication for a medical reason. 9 times out of 10, the recommendation is going to be taper that medication. Sometimes there are more serious withdrawal effects that are the reason for that, but also some of the withdrawal effects can just be uncomfortable for the patient. And so to try to kind of minimize that and make it a more smooth transition, the tapers are recommended. I think the other advantage to tapers is that it means more often follow-up, and then kind of in the middle of a taper, you might be able to identify, oh, this patient's symptoms are back at this dose. Now we kind of know at what point we need to act, do something different, increase the dose back to that level, slow the taper, all those kinds of things. So by doing that, we can kind of have multiple steps where we're assessing and figuring out what's the right next step. All right. We have 2 minutes. Any other questions?
Yeah, anyone else have a question for Katie?
I guess I'll ask this question. If you were talking to somebody that like wanted to get pregnant, but they didn't want to be on meds during their pregnancy, how far in advance would you say to start tapering off meds?
It's a loaded question.
Sorry.
I mean, in that it's going to really depend on the scenario. Why are they taking that medication? It's almost always going to be a risk-benefit sort of assessment for pregnancy. In a lot of scenarios, the risk outweighs the benefit of coming off the medication. In a lot of these, the patient needs the medication to kind of continue to function well and to be able to take care of a child and also to grow a child that's healthy. So it's kind of an interesting concept where there's a lot more risk versus benefit discussion there. I would say that it depends on the medication too. Some of these medications, if we're talking about certain antipsychotics, like aripiprazole or cariprazine, those have really, really long half-lives. Like they're in your body for weeks and weeks and weeks after you stop the medication. So if you want to be completely off that medication, that recommendation is going to depend on the medication, unfortunately. So that's one of the things we think about half-life. How long is the drug going to be in your system, and how long is it going to take to be like completely eliminated? So might depend on the goal there, if we want to be totally off medications in terms of how early you would need to like start a taper and start that whole process. I know that's not like a yes or no answer, but it's messy.
No, it helps.
Yeah. I want to thank Katie for being here tonight at 7:30. We've always been really, good about ending at 7:30.
Of course.
Anyone that's interested in the slides, please make sure that you email me, and we'll get them to you right away. My email's right there in the chat. Katie, this was absolutely amazing.